10.
8, so we should start. Yes, we should start.
Okay, fine. So a very good morning to all of you on a Sunday morning. I understand it's a Sunday morning and you all are all here today. And welcome to the fifth series, edition 1. It's great to see that students have come here on a Sunday morning. I'm hoping that still more would join. I'm Dr. Vinona Fernandez, working as a consultant psychiatrist at IPHB, and I'm happy to moderate yet another session, the first for this year, held by my committee, the PG Education Subcommittee of the Psychiatric Society West Zone. I'd like to begin by requesting our president, Dr. K.K. Mishra, to say a few words. I don't know if he could. Is he there?
Good morning.
Good morning.
Thank you.
Good morning,
I welcome you all to the, because I'm traveling, I welcome you all to the, welcome you to the first program of the West Zone for the, which is conducted by the PGCME group. And last year they have done a great job and we expect the same for this year also. And just few word about CL psychiatry. And CL psychiatry is actually having a good reputation now among the all the other specialists, from medicine to gynec to pediatric. And like important aspect of CL psychiatry is how much you prove your efficiency, because day by day actually psychiatry is becoming without neurology, and we are going towards the biology, but we are missing on the neurology. So I'll focus on these aspects. We must be strong about our neurological evaluation and neurological diagnostics can help us in the process of either dealing with delirium or in the other specialty also, like in the gynec and pediatric, about this postpartum depression and in childhood disorders. Now the neurodevelopmental disorders in the childhood are morely progressing toward the pediatric side. So we have to look into that aspect, the not only the behavioral aspect, only also the treatment aspect of autism spectrum disorder, ADHD. Then we can have a good reputation and good connection between the other specialty, which will be very much improvement in bringing to us the reduction, the stigma reduction and awareness improvement. With this short, we will not take much time because I'm traveling. So with this short time, I welcome you all and wish you best for the program. And the PG Psychiatry Subcommittee has been always in the forefront. So I congratulate all the members of the PG Psychiatry Committee, from Sushil to Anana and all the new members. And we expect a good number of webinars in this year. Welcome you, and thanks to all the participants of the PG students, and we expect them to do well in the subject. Thank you very much, and we wish them all the best. When I think exams are starting, most of the people exam are starting. I wish them all the best for the finally. I think final student must may not be there, but through their juniors, I express my best wishes to them. Thank you, Irina. I'll just stop.
Yeah. Thank you, sir, so much for those
Thank
encouraging words. This year, we are thrilled to continue to have Dr. Sushil Gawande as chairperson of our committee. His dynamic and enthusiastic nature and his ability to think unique and out of the box is something we all admire. I now request Dr. Sushil to kindly say a few words.
Thank you, Venona. Respected Mishra sir, today's moderator, Dr. Venona, our faculty, Dr. Malay Dave sir and Dr. Anil Rane sir, and my dear students. Thank you so much for joining on this Sunday morning. My thanks to Malay sir and Anil sir for sparing Sunday morning for us. And why did I choose this topic? So in our exams, we have child cases, geriatric cases, and even general psychiatric cases. But in exam, we don't have consultation liaison cases. But at the same time, during our residency, we realize that we very often or every day we need to go to medicine wards and surgery wards, burn wards, ICU to see cases and where our opinion matters a lot. So to bring that under proper guidelines and to understand the nature of dealing with consultation liaison psychiatry, I thought this program would be useful for the students. And happy to see that 45 students have joined. And I request all PG students to please motivate your colleagues to join these scholarly Sunday sessions, because most of the times they are exclusively carved for your need, and it would cover whatever best is needed during the residency. So without a further ado, I hand over the mic to Venona and wish her all the best. Over to you, Venona.
Yeah, thank you, sir. So I'd like to commence today's session by first introducing our faculty. Both our faculty for today are well accomplished teachers with a large number of publications to their credit, both recipients of the prestigious A.V. Shah Award and the BPSS Award. Our first faculty is Dr. Malay Dave. He is working as a consultant psychiatrist, currently doing his private practice. Has worked as a PG teacher for almost 12 years, has several publications, was also the honorary president of the Bombay Psychiatric Society and member of various subcommittees at the IPS level. Uh, thank you, Dr. Malay, for being here. Dr. Malay, yeah, okay, you're there. Our second faculty for today is somebody I've known for 17 years, my teacher initially and now my colleague, Dr. Anil Rane, working as a consultant psychiatrist at IPHB and also the medical superintendent of the hospital. He also has several publications to his credit, was the honorary president of the Psychiatric Society of Goa, and is also a member of the various subcommittees of the at the IPS level and Best Zone. So welcome, Dr. Rane. Okay. Moving over, we are going to have two case presentations for today. Our first presenter is Dr. Kaushik Biswas. He's a second-year junior resident at AIIMS Nagpur. He will be presenting his case for 10 minutes, and then we'll have a question and answer session probably for 15. And then we move on to our next presenter. If I'd like to begin by saying if the audience has any questions or queries, they may please type the same in the chat box, and then we will take them to the faculty. Dr. Kaushik Biswas?
Yes, ma'am.
Yes. Okay. Dr. Malay, Dr. Anil, are you all?
Yeah, yes.
Yeah,
sure.
okay, yes.
So, ma'am, can I share my screen?
Yes,
now?
please. Yeah, you may.
Ma'am, is my screen visible?
Yes, it is.
Okay.
Yes.
Good morning, everybody. Good morning, respected faculties, seniors, and my colleagues. I am Dr. Kaushik Biswas. Today, under the guidance of Dr. Shilakshmi and my moderator, Dr. Dibyata, I will be presenting a case titled Unmasking the Mind, a case of neuropsychiatric SLE. As we know, systemic lupus erythematosus is often called a great imitator. But in this case, they didn't only imitate the symptoms, but also masked the underlying systemic pathology for months. So, in this case, we will try to look beyond the surface of acute behavioral changes in autoimmune patients. So at first, we will see the patient profile. She's a 22-year-old female, educated till class 10, born second born of non-consanguineous marriage, and a resident of Wardha from lower middle socioeconomic status. Our first involvement began when a consultation liaison call was sent from the medicine department. The primary team was concerned about the acute behavioral changes. So in this case, it is important to note the setting. It wasn't a patient walking into a psychiatry OPD. This was an inpatient admission for a severe autoimmune flare, complicating the clinical picture with the questions of is it a medication into side effect versus is it a disease progression. So we'll dive into it. So to answer the question, we first have to review the medical history. So as mentioned in her previous notes, the medical history suggested that her systemic diagnosis was very recent in August 25. When she presented first time to the medicine OPD, there was non-itchy malar rashes, photosensitivity, alopecia, and multiple joint pain, the classical type of systemic lupus erythematosus. So she was she was diagnosed with SLE, and she was started on treatment. She was adherent to treatment for 1 month, but there was non-compliance, and she lost to follow-up. So in 2 months, 3 months later, she again presented to the medicine OPD. This time was with flare of symptoms, and this time she required admission and was started with cyclophosphamide. Um, so, the, so after giving the second dose of cyclophosphamide, there was family members reported worsening of their restlessness, behavior symptoms like hyperactivity, irrelevant talking acting to family members, disinhibition in the ward towards the hospital staff, towards the other doctors, hypersexual behavior, and over familiarity, and decrease in for sleeping for nearly 2 to 3 hours. The timing is very important there. The symptoms worsen, according to family members, the symptoms worsen soon after the dose of cyclophosphamide, which created a strong bias towards a toxic or drug-induced etiology. When we saw the patient for the first time, in her mental status examination, she was hyperactive, restless, unkempt. Her psychomotor activity was increased. In her mood was irritable, labile also. In speech also, spacer of speech was there, flight of ideas was there, and grandiose and hypersexual themes were persistent in her MSc. So it confirmed a manic episode in her MSc. But now I want everyone to focus on the timeline. And this is where the diagnosis was truly made. If we only look at the August and October features, we will see a lupus patient getting worse. But if we go back in the time in the past, after taking a detailed history, we got to know this is the features of October and August. So after taking detailed history, we got to know there was a depressive symptoms in February. And that time she consulted a private psychiatrist and she was started with acetalopram and she responded well. So the timeline reveals a critical gap. The psychiatric symptoms, the depression, predated the somatic diagnosis about for 6 to 8 months ago. And and it is very well documented in literature that neuropsychiatric manifestation can present before SLE, often misdiagnosing as primary psychiatric illness. And currently, she is in her follow-up. There is mild hyperactivity, mild irritability present, but she is maintaining well. So, let's dive into the early identifier. In February, she had low mood, she had anhedonia, and she was treated symptomatically that time. So why it is important? Because it somehow establishes that her brain was vulnerable to autoimmune process before any medication like steroid was introduced. It proves the organic diathesis. This depression was likely the result of early cytokine-mediated inflammation, autoimmune activity like anti-ribosomal P, NMDA, and affecting the limbic system long before the systemic rash, systemic inflammation came into the picture. So, mm, huh. So where the diagnostic dilemma came when we first saw the patient, there was we had two differential. One was steroid induced mood, and another was neuropsychiatric manifestation. So what was the pivoting point that took us to the diagnosis of neuropsychiatric SLE, that is the past depressive episode. And initially, the high dose of steroid coincided with the flare of symptoms. Was it a temporal correlation? It can be acute onset also. But after taking detailed history, it was made sure that it is a continuous illness. It is an exacerbation of illness, not some drug-induced manifestation. So how we manage the patient, the management challenge. As first, olanzapine was initiated. And it is also very critical teaching point. Like after starting olanzapine, we build it to 10 mg. But on 10 mg, she developed a severe motor restlessness, akathisia, initially, completing the clinical picture. Because it can be mistaken as the worsening of mania, which will, if we diagnose as worsening of mania, we will increase the antipsychotics. But we took our time, diagnosed the patient. It was not worsening of mania. It was a side effect of the medication, which already also emphasized the organic pathology. So we caught it. We identified the motor restlessness as extrapyramidal, and as in case of these medically ill brains, which are more sensitive to side effects of medication, the start low and go slow method was applied. So we decreased the olanzapine to 5 mg. We added benzodiazepine and propanol and gradually retitrated once akathisia resolved. So, what is the key takeaway from this case? The key takeaway are that history matters. Exploring the prodromal depression was key in diagnosing the neuropsychiatric SLE over steroid psychosis. And what is the complex so history is the king here, and also the mask. The psychiatric symptoms often precede the systemic sign in autoimmune disease. Always, so it is always in young females with fast onset mood disorder with no apparent stressor. It is always better to ask for rashes and joint pains, and so it often presents to us in complex presentation. Mm, and also the last point, coordinated care, like we treated in this case the medicine treated the fire, which is the inflammation, and we treated the smoke, that is the behavior. So neither would of us would have succeeded if different branches didn't treat their respective symptoms. To coordinated care, treating alongside and managing in CL cases and referring to each other was a very important point in this case. So um, mm, with this point, I would like to conclude my presentation and emphasize on the seeing patient in CL calls and coordinated care, multidisciplinary approach. And here I end my presentation, and thank you for your attention, and I am open to your questions. Thank you.
Thank you, Dr. Kaushik. Over to you, Dr. Malay and Dr. Rane.
You want to start, Malay?
No, you can ask. I'll just.
Kaushik, thank you for this case. I mean, though SLE is not the usual liaison call you'll get, but once in a while you will get it, and it's good that you brought this case for attention, for study and discussion for this case.
Thank
what
you,
I'm
sir.
trying to understand from what you've said is that you're saying this current manic symptom is a manifestation of SLE or is it a manifestation of the treatment that has been given?
No, it is manifestation to SLE, like that the thing I discussed, like
You want to go with the understanding that this is a continuation of neuropsychiatric SLE.
Yes, sir. Yes, sir.
But that the symptoms came up after admission and initiation of treatment, doesn't that have a back?
No, sir, it didn't came up. The clinician noticed it after that, but on state exploration, it was there. Like as I mentioned in the slide, it was there for last 10 days before admission also. But the treating clinician noticed that correlated with after giving cyclophosphamide, but it was present for last few days also.
So you are saying that the manic-like symptoms and activity, irritability was there at the time of admission. When she came
Sir,
for
I'm not able to hear, sir. Sorry,
We are not able to. You're not audible, Dr. Rane.
not audible.
No, it's like breaking up in between.
Malay, you can take over till I start.
Okay. So, would you like to take this patient for a follow-up?
Yes,
In
sir.
the
We are keeping her in follow-up.
So what happened after you started treatment for this mania-like symptoms, and was there a follow-up after you started something, and what happened over a period of time? Do you have any information on that?
Yes, sir. So after she got discharged, she followed up once, and that time her hyperactivity has resolved. Mild irritability was there. She was on olanzapine 20 mg, and 2 days back, after I submitted this case for the presentation, she got admitted in the medicine for her third dose of cyclophosphamide. Currently, she is better. We have seen her on CL call, and we have continued the olanzapine 20 mg for now. But her hyperactivity, irritability is currently better than before.
Okay, so another thing is that you said that this was the time that you got a call was the second cycle of cyclophosphamide,
Yes, sir.
and now she has come for the third one.
Third one. Yes, sir.
So what happened after the first one?
Nothing, sir. Like after the first one, there was no she was no psychiatric symptoms. She was doing well. That is also a point towards the organic pathology. If it was due to cyclophosphamide, there was high chances of it is happening after the first dose of cyclophosphamide. Uh, but that time she was maintaining well. Her only SLE features was there, and she got discharged after taking cyclophosphamide for 2 to 3 days, and again then came back after 2 weeks for second dose. That time we got the CL call.
So before I hand over to Dr. Rane, so what are you thinking in terms of long-term continuation of something
So
from our side?
from our side, sir. We will, as olanzapine is effective in mood disorder, bipolar mood disorders also. So we, as of now, when we'll continue her on olanzapine, and long-term follow after 6 months or 1 year, we'll observe if there is any side effects or not, or any symptoms or not, and then decide accordingly.
What happens if there's a depression episode in between?
Sir, according to CanMed guideline 2018, olanzapine is a good molecule which will also help in maintenance and further acute exacerbation of depression. In spite of that, if depression is there, we have to evaluate for the adequate dose of the medication, and at first we can consider increasing the dose, but in this case there is, I don't think there is need of in adding any antidepressant, but we can consider another mood stabilizer if required.
Okay, Dr. Rane, your
Yeah.
audio is settled.
Am I audible?
Yeah,
Yes,
better
sir.
now.
Okay. So why would it be important, Kaushik, for us to have this very clear distinction whether this is SLE or whether it is treatment induced? Besides cyclophosphamide, did she get any kind of steroid?
No, she was previously given a methylprednisolone, but on methylprednisolone there's a minimal improvement. That's why cyclophosphamide was initiated.
Would you say that cyclophosphamide itself can precipitate neuropsychiatric symptoms?
Yes,
and
sir.
it is dose related. The
Yes,
cumulative
sir.
dose of cyclophosphamide. Even if it was not there at the first instance,
yes, sir.
instance it could have triggered. Why is it important for us to know this difference?
So because, sir, if it is cyclophosphamide induced symptoms, we need to first consider decreasing the dose of the cyclophosphamide, and but if it is not a neuropsychiatric SLE, we will continue the anti-inflammatory drugs and may consider increasing it to stop the neuroinflammatory process. So the mechanism of action is both very different. So we have to act on mechanism of action. That's why it is very important to decide it is cyclophosphamide induced or not.
Approach would be different.
Approach would be very different, sir.
Any other explanation to have any neuropsychiatric condition in this?
Any other explanation such it started with depression, and it was in that depression there was no low mood anhedonia, but no depressive cognition, no precipitating factor was found. So it can be mostly attributed to the neuroinflammatory inflammation in the central nervous system. So, and manic symptoms also related to that. And in ACL, it is found in 90% of cases there is neuropsychiatric manifestation. So it can be explained by that. That is one point. Apart from that, sir, no, sir.
Metabolic causes.
Hello.
Sir.
Yeah, Kaushik, what was the inflammatory marker profile for this patient?
Inflammatory marker profiles, sir. She had anti-ribosomal T protein was her elevated, increased, and apart from the NA was positive, and this two was positive. Sorry. So her ANA was positive for more than 1/80, which is required for the diagnosis of SLE. And apart from that, anti-beta-2 glycoprotein was raised, and anti-ribosomal P antibody was raised, which, like there is in literature, anti-ribosomal P antibody is most suggestive of neuropsychiatric manifestation, approx 36 to 40% cases. So, which is also a marker towards neuropsychiatric SLE.
So suppose looking at hindsight, in February this year when she started developing depressive like symptoms,
Yes,
would any of this marker would have come positive?
Yes, sir. Like
As positive to the point that it will you would be confident, or the physician would be confident in starting something for the SLE.
I don't exactly know about, sir, but serum diagnostic marker is not that sensitive or specific. But if we do the CSF biomarkers, if it is available here, we can do the CSF biomarkers like the CST6 or TCN2 markers that can come positive at early stages of disease. But serum markers are not that sensitive or specific at very early stages.
Yeah. So when you did the consultation with the liaison with your medical medicine department or the rheumatology department, did you suggest that you do a CSF marker to be 100% certain that this is a CNS involvement, primary CNS involvement, or of the SLE process? Because otherwise, whatever you're suggesting in terms of whether it is just new, it is just kind of what came first, what seems to have come first, and it's pretty much it's still a hypothesis. So when you need to be sure, especially in proven inflammatory disorders, you will have to have some markers which are more robust. So did they do it? Did you suggest them?
We suggested them, but it was not done due to logistic issues like the affordability issues and all. But in the next time they come, I will again reinforce it to get done, sir.
Okay.
There's one question which comes from one of the participants, and also I would like to know. She was on treatment for depression, so the participant wants to know why this is not a switch. And my question to you is, why is this not a primary psychiatric condition?
There was not switch. She was on treatment for 2 months. She got better, and not a primary exam, because at that time the depressive features there was no acute no stressor and no depressive cognitions was there. It developed, so it was more sensitive to organic cause. But yes, sir, that can be a differential. Obviously, that it can be a different. Both things can be different. But if we trace back to the history and keep the clinical picture one by one, it was more suggestive of neuropsychiatric actually. But obviously, sir, it can be a different entity also.
Anything else, any other information that would help?
Sir, I am not able to understand, sir.
Any other information would have helped you?
What information?
Whether it is a primary condition, family history.
There no significant family history is there, and along with that, there is no like stressor or cognitions were there that took me the clincher.
Usually it is best, and when you have an organic condition going, it's best to presume that it is an organic condition rather than a primary condition.
Yes, yes.
So you chose olanzapine, right?
Yes, sir.
What are the options you had?
Sir, I'm still unable to hear you.
What other options for treatment did you have?
Dr. Rana, you're not very audible. There is, I think, a little bit of it.
Other options we had could have been quetiapine and along with olanzapine, because this with then NPSL, the symptoms can be variable, so both can be act as a mood uh, antipsychotic dose and mood stabilizer dose also. So quetiapine could have been also an option in her case.
Yeah, the question here is by Dr. Vidhu Arora, if you can see on your chat, is that if this patient had depressive episodes in the past and now she's having manic symptoms, can it be a switch because of antidepressants? So was this depressive episode treated in the first place?
Yes, sir. The episode was treated in the first place, and they stopped the medication after 2 months. So she was off any antidepressant for 4 to 5 months. So it is unlikely to be switched because she was not on antidepressant that time.
So there is no temporal correlation, you say,
Yeah.
between the use of antidepressant medicines and the current.
Yes, sir.
This,
Because
okay.
it started in February, she took medication till March, mid of May. Then she stopped. So till March, April, then she stopped. So, and the symptoms started in October. So there is no temporal correlation.
So tell me, what do you understand by the term illness behavior?
Illness behavior, sir. Like in here, while she started having these symptoms, so where like I'm not this like she so I don't I'm not.
So illness behavior is these are non-specific symptoms at the beginning of some illness. It can be a short illness, it can be a long illness.
Yes, sir.
But before the actual symptoms of a physical illness will manifest,
Yes, sir.
okay, there can be a phase where there are this non-specific kind of symptoms which can be clubbed as illness behaviors.
Yes, sir.
So whatever is the pathology of the disease,
Yes, sir.
it will start someday to cause symptoms. But before the symptoms or the phenomenology really crystallizes, there is a phase when there are non-specific symptoms. So something roughly like what we understand by prodrome of our illnesses, which are
Yes.
non-specific. You don't know where
Yes.
it is heading.
Yes, sir.
So do you think that when you say that this patient didn't have any depressive cognition or whatever, was it just a illness behavior rather than,
Yes.
depression?
Yes, sir. It could have been like she was not our follow-up. She was treated from outside. Only the mean we got the old treatment records, and mother was giving history of low mood, decreased interest in activities. So, and it was mentioned that depression started in acetyl from 10 mg. So it can be a illness behavior, definitely, sir.
Because the thing is that when we come to this kind of trying to differentiate clear cut whether this is depression, primary depression, or it is a process or a part of the primary medical illness, sometimes this exercise is not needed. Okay, we do not really go for stressors and all, because there are many patients who come to us with let's say the first onset of anything where the stressors are not there.
Yes, sir.
So a stressor not being there doesn't mean that the disorder is not primarily psychiatric, as you would like to say.
Okay, sir.
Even family history is okay, it is contributory, but it is not mandatory.
Yes, sir. Yes,
so whatever the patient has or presents with has to be evaluated on its own merit. Additional
sir.
features are additional features. They may not be there, they may be there, they may be present in varying plus minuses. So another question comes from Dr. Sri Lakshmi Vaidyanathan. So if we consider this as an independent psychiatric diagnosis, bipolar, what would be the ideal choice of medication, keeping in mind comorbid SLE and interactions? So what would you continue her on?
I would like to continue her on olanzapine only, like as there has been a significant improvement of the patient, and as there is improvement, there is no need of change the medication as of now. And in sir, that will be my hypothesis.
So just to add on, yes, Doctor.
No, you continue, Malay. I'll follow up.
So my last question is this: if she develops depressive episodes again, okay, we do not know what is going to happen 2 years
Yes.
down the line, 5 years down the line, 10 years down the line, because there are two presentations of illnesses, whatever it is.
Yes, sir.
Whether we say they are two different or two say both
sir.
being part of the same illness. So we have an SLE and let's say we have got mood disorders,
Yes,
and
sir.
both are likely to be very chronic
Yes, sir.
with a lot of fluctuations
Yes,
in the SLE status, fluctuation in the mood status, whatever.
Yes, sir.
So the question is that if she develops depressive episodes, you have tried to answer this.
Yes, sir.
But what also happens is that as disorders progress, there is a lot of let's say in very simple words, neuron burnout. So as the disease progresses, the SLE presentations can become more chronic.
Yes,
Mood disorders, when they become chronic, it is more on the depressive side rather than the manic side.
Yes, sir.
So you will have to take a call whether you would like to, would you like to give antidepressants, so it's SSRIs or SNRIs over a long period of time.
Okay, sir.
Because
Okay, sir.
what guidelines say you give atypical antipsychotics or this thing, when we look at cognition, antipsychotics and mood stabilizers like anti-epileptics, they are cognitive dullers. They dull down the cognition.
Yes, sir.
So if a patient is going to be in a long phase of depression, increasing the dose or keeping on adding may be counterproductive.
Yes, sir.
So in such a situation, what would be your take on SSRIs and SNRIs? Is there an additional value of using those medication in this case?
Okay, sir. Like sir, I couldn't find any literature about that, so I was not able to read. So I'll read about it, sir. Sorry, sir.
So just no, that's fine. The point is that over years, with so much use of SSRIs and SNRIs, what is understood is that SSRIs, they have got by themselves a anti-inflammatory effects.
Yes, sir.
So when it comes to long-term maintenance,
Yes,
that
sir.
would be a better option rather than anything else.
Yes, sir.
And they may not necessarily precipitate psychosis or mania.
Okay, sir. I'll keep it in mind.
So clinically,
Yes, sir.
this is what has been said. Now, when you go by guidelines, the problem is the guidelines are based on RCTs or studies, and studies are based on certain criteria. Let's say for criteria, DSM-5 criteria or ICD-11 criteria for this disease. Now, criteria are not pathogenesis based or etiology based. They are symptom clusters.
Yes, sir.
So that is why this confusion comes, whether this came first or that came first. Is this depression or is this something else?
Yes, sir.
It's whatever said and done in very simple terms, this is all happening in the same person.
Yes, sir.
Okay, so even though she may not have a family history, she may not have a stressor, an illness like this can also precipitate certain other mechanisms which can cause symptoms of depression.
Yes, sir.
Because one of the things that is very common in chronic psychiatric illnesses is the underlying inflammatory states.
Yes, sir.
They are not necessarily leading to illnesses, but they can cause this kind of subtle changes in circuit function and cause problems like that. Yeah.
Yes,
over to you, Doctor.
Yeah, I'm sure we have discussed this. We got one more case. Just for the discussion purpose, what would you say is your limitations or things to consider if you wanted to use other mood stabilizers?
Like lithium. Lithium could have been used in her case, and it has good evidence in this case. And limitations of other mood stabilizers. Your question was, why didn't I consider other mood stabilizers?
Just for the discussion purpose, not necessarily for this. When you have an SLE case and you need to choose a mood stabilizer now, because you got manic episode, right? You would be tempted to maybe use valproate, maybe use lithium for rapid control of symptoms, or even carbamazepine. What would be your considerations given the medical comorbidity?
Achha. Given the medical, lithium would have been a good choice in this case, but given the medical comorbidities, olanzapine was chosen because
What would be the
there,
problem in SLE using lithium in SLE?
there would be in lithium in SLE, it can cause further neuron burnout and the non-compliance also, which can
Would the
worsen the.
kidney be affected in SLE?
Yes, sir. There is nephritis. Yes, sir. Nephritis, lupus nephritis can be.
There's lupus nephritis, right?
Yes,
So your
sir.
long term will be a problem.
Yes, sir.
Would be able to use carbamazepine.
No, in carbamazepine, um, I am not sure.
Carbamazepine will be a problem to you because of the enzyme induction. Because
Yes,
your enzyme induction and it will interfere with the cyclophosphamide metabolism.
yes,
What
sir.
would be the implication if you use valproate over it? And this is something you will have to consider given the age
Yes,
of the patient and the gender of the patient.
yes, sir. Yes, sir. She's a childbearing age. Valpert is not a good molecule for her. It can.
Any additional reason why valproate may be in this particular case?
I'm sorry to interrupt. This is the last question, and for want of time, we will have to move to the next case quickly.
Because this is something, and when this lady comes to you with follow-up, as Dr. Malay
Yes,
said, she will follow up with you, right? Because you need
Yes,
to
sir.
monitor for next 1 year or so.
Yes, sir.
Fertility issues will come up.
Yes, sir.
Cyclophosphamide is an antigonadal toxic kind of a medication.
Yes, sir.
That's a very important discussion you're going to have.
Yes, sir.
SLE itself is going to affect all of this, and all the reproductive parts will be involved. So it's an important. We are not just getting many symptoms, but we are going to look at the implications of all our treatment and management, considering SLE is ongoing in this patient.
Yes, sir.
In case your olanzapine was not able to control, what is the other option that you would have?
Like quetiapine would have been a good choice, and if there is in future there lamotrigine can be a good choice.
Yeah, would you consider ECT?
Yes, like if there was no control, we would have considered ECT. Yes, that can be considered. Yes, sir. But ECT doesn't have much of evidence in it will call.
It's a clinical call. If your medication, you're hamstrung by the choice of your medications.
Yes, sir. Yes, sir.
Okay, because of lack of time, I think we'll move on to the next case. Thank you, Dr. Kaushik, for this interesting case. I mean, though SLE is not a very common presentation, but I mean, the discussion did evoke a lot of thinking. Moving over quickly to the next case, Dr. Aditya Tete, third year JR from IGGMC Nagpur. Dr. Aditya?
Good morning.
Yes. Would you quickly go through your case so that then we
Yeah,
can
sure.
go
I'll just share my screen.
Dr. Aditya, you're on mute. Hello.
Yes.
Yeah, please go ahead. Yeah.
So, good morning, everyone. Good morning, respected teachers, the moderators, and my dear colleagues. So, today I will be presenting a case from Consultation Liaison Psychiatry, which explores the interplay of alcohol withdrawal, delirium, and medical comorbidity in an ICU setting. So, as we all know, that delirium is one of the most common indications for which we get a consultation liaison reference, and it is particularly a serious condition because it causes a lot of distress to the patient as well as the caregivers, because it causes a burden in the sense that it increases the length of the stay of the patient in the hospital or in the ICU, and there is increased risk of cognitive decline. If the condition is not properly managed, there is increased risk of functional decline, and there's also an increased risk of mortality as well. And why it is important to explore this topic is because it requires a multidisciplinary approach to manage this condition as well as prevent the complications. So let's begin without much further ado. So I am presenting the case of a 43-year-old male who is educated till 10th standard and is a rickshaw driver by occupation. He belongs to the low socio-economic class, is married and Hindu by religion. The person is a resident of Nagpur and the mother tongue is Marathi. The informant is his wife, and the informant is adequate and reliable. So the patient presented to the casualty of Indira Gandhi Government Medical College on 18th November with the chief complaints of hemoptysis since 3 days, cough with yellowish mucoid expectoration since 5 days, breathlessness since 5 days, and fever since 5 days. The patient had a past medical history of pulmonary TB 10 years ago, and he had completed 6 months of treatment. The detailed records were not available. And on chest imaging, that is chest X-ray, it was found out that the patient has right-sided tracheal pull with fibrocalcific changes and left-sided raised bronchovascular markings. So the patient was admitted under in a ward under the Department of Respiratory Medicine, and the provisional diagnosis or the impression was kept as post TB sequelae with hemoptysis under evaluation. On the next day, that is the day 2 of admission, a psychiatry consultation liaison reference was given in view of alcohol use in the patient. And on history, it was found out that the patient had sleep disturbances and tremors and sweating, restlessness, and irritability since the past 5 days. The patient had a 10-year history of alcohol consumption, which initially began as occasional consumption of alcohol once or twice a month, and which slowly progressed to daily drinking. And there was progressive increase in the consumption in the amount of alcohol that the person consumed. And the current intake was around 270 ml of country liquor per day since the past 4 years, and history of eye opener drink was also present. The last intake on the day 2 of admission of the last intake of alcohol was 6 days prior to the day of examination, and there was history of the similar withdrawal symptoms in the past, but there was no history of seizures or perceptual disturbances or altered sensorium in the past. So basically, there was no history of complicated withdrawal. There were a few medical comorbidities present in the patient, which was thrombocytopenia was noted. And on CT pulmonary angiography, the patient showed dilated right bronchial artery and dilated right intercostobrachial trunk. On 2D echo, the patient had mild mitral regurgitation, tricuspid regurgitation, as well as pulmonary artery hypertension. On on general examination, the patient was thin built and tremors were seen. Pallor, as well as pallor and clubbing was also present. On mental status examination, the patient was conscious, cooperative, oriented. The patient was lying comfortably on the bed. The patient was on oxygen support while in the ward. And the psychomotor activity was normal. Rapport was established. Eye-to-eye contact was initiated and maintained. The patient's mood was euthymic and affect was mood congruent. There were no thought or perceptual abnormalities. So a provisional impression of alcohol dependence with uncomplicated withdrawal was made. And considering the patient's comorbidities and admission to the respiratory ward and the respiratory complaints, the treatment was initiated as lorazepam 1 mg BD. So a total of 2 mg lorazepam was started for the patient, and thiamine 300 mg injection thiamine 300 mg in 1 pint NS. This treatment was initiated, and the patient and it was advised to watch for respiratory depression for the doctor in charge in the ward. So on the day 3 of admission, the patient were tested positive for influenza B, as well as there was an episode of atrial fibrillation, for which a physician reference was done, and the patient was started on medications for arrhythmia. And the serum sodium on this day, that is day 3, was slightly on the lower side, which is 132 mg per dl. So on the day four of admission, the patient started complaining of severe breathlessness as well as tachypnea, and the oxygen saturation was deteriorating. The patient was on 4 liters of oxygen, and yet the SpO2 was not being maintained. So the patient was shifted to the respiratory ICU, and on chest X-ray, the changes in the lungs were suggestive of aspiration. Uh, on the next day, for continuation of in view of continuation of medications, on day 5 there was another psychiatric consultation liaison reference given, and this time the patient was complaining of decreased sleep at night and drowsiness during the daytime, as well as irritability since the past one day. And the patient was also trying to pull out IV lines and the O2 mask. And the patient had occasional history of not recognizing family members, and there was history of occasional irrelevant talks as well. On this day, that is day 5 of admission, the last intake of alcohol was 9 days ago, and there was significant hyponatremia noted in the patient, which was the um, serum sodium was 128 mg per dl. So, and lorazepam 1 mg nightly dose. On the previous night, it was withheld while the patient was being shifted to the RICU. Lorazepam 1 mg nightly dose was withheld. And on the next day, the psychiatry call was done. On the same day, mental status examination, the patient was drowsy, minimally cooperative, minimally communicative, and not oriented to time, place, and person. The patient was restrained to the bed, was on non-invasive ventilation. The patient's psychomotor activity was decreased. His speech was coherent but occasionally irrelevant. Rate tone volume was decreased. Mood was not conveyed, and affect was perplexed. And the rest of the MSE could not be assessed as the patient was drowsy and very minimally communicative. A diagnosis of delirium, according to DSM-5, a diagnosis of delirium due to another medical condition was made, and according to ICD-11, delirium due to multiple etiological factors was made. The patient was advised injection haloperidol 2.5 mg intramuscular SOS if the patient is extremely aggressive or irritable, and thiamine 300 mg was continued. The patient was started on melatonin 3 mg HS, that is nightly dose, and lorazepam was withheld. Along with this, other non-pharmacological measures were also advised to the patient, such as the patient has to be frequently reoriented and reminded about the time, place, and person. The patient should be shown and be exposed to familiar things and objects, along with the other non-pharmacological measures. On day 6 of admission, the patient on day 6 of admission, there was another psychiatry reference which was done, and this time the patient had an additional complaint of picking out on the bed sheet and picking out on the clothes. The physicians were addressing the hyponatremia, and there was a slight improvement in the serum sodium level on the next day. And when we saw the patient on psychiatric examination, the patient was drowsy, minimally cooperative, communicative, and just like the previous day, the patient was lying on the bed, was on NIV and restrained to the bed. Carpologia was present. Psychomotor activity was slightly increased, and the speech, as it was on the previous day, occasionally irrelevant, and rate tone volume was decreased. Affect was perplexed, and memory was impaired. The patient was on the next day. We decided to add a tablet haloperidol 0.25 mg TDS to the patient, and injection haloperidol 2.5 mg IM-SOS was continued. Thymine 300 mg was continued, and melatonin 3 mg HS was again continued. 2 days later, that is on day 8 of admission, there was when we saw the patient again, there was complaint of occasional irrelevant talk, and irritability had significantly reduced as per the informant, that is the patient's wife, and the sleep quality had also improved. Serum sodium was returning to the normal values. It was 136 mg per DL. And on MSE, patient was drowsy, less cooperative. The patient was oriented to place and person. Patient was lying on the bed, and this time the patient was not restrained because the behavioral symptoms were in control. So uh, the patient was not restrained anymore. Psychomotor activity was normal as opposed to increased on the MSE 2 days prior. The patient's affect was still perplexed, and thought and perception. There was no thought or perceptual abnormality which was detected, and attention was aroused but ill sustained. We advised to continue the same line of management because we saw quite some improvement in the condition of the patient on day 8. On day 10, that is again 2 days after the previous CL reference, when we saw the patient was complaining of occasional irritability. All of the rest of the symptoms were maintained on medications, and the informant reported significant improvement on our line of management, as well as the physician and the pulmonologist were continuing their line of management to control the viral infection. The patient was on oseltamivir and other broad spectrum antibiotics and certain antiarrhythmics as well. So our management, when it comes to the behavioral symptoms, on day 10 there was significant improvement in the general condition of the patient. On mental status examination, the patient was conscious, cooperative, communicative, oriented to time, place, and person. Patient was lying comfortably on the bed. The patient was still on NIV. Psychomotor activity was normal. Speech was continuous, coherent, relevant. Rate tone volume was slightly decreased, and no other thought or perceptual abnormality could be elicited. The patient's attention was aroused and sustained. Memory was intact on day 10, and judgment was also intact. We decided to continue. The patient was still in the ICU. The patient was continued on melatonin 3 mg HS and injection haloperidol 2.5 mg deep IM SOS was advised just in case the patient becomes agitated and aggressive. So the final diagnosis, according to ICD-11, was made as delirium due to multiple etiologies, and according to DSM-5, delirium due to multiple etiological factors. And the multiple etiological factors being severe respiratory illness, that is influenza B and aspiration. And it is, according to the pulmonologist, it is suspected that initially when the patient walked in with yellowish green sputum and mucoid expectoration, there is a possibility that there was some underlying bacterial infection also. Although the culture tests were negative, they tested negative for the bacteria, but it is still suspected that and influenza B, it could have been uh, a hospital acquired infection as well. So there was multiple infective etiologies in this patient, as well as there was an episode of atrial fibrillation, and which could have led to hypoxia, because one of the theories in the pathophysiology of delirium is cerebral hypoxia. So that is also one of the contributing factors. There was, as we saw in the case, there was significant metabolic disturbance, that is hyponatremia. Rest of the Although the patient has history of chronic alcohol consumption, the liver enzymes were not quite significantly deranged. So the only metabolic disturbance we could point out to was hyponatremia. That's why I did not mention the other values of the other electrolytes in my presentation. And ICU related factors, as we know that ICU stay by itself is one of the risk factors for developing delirium in a patient. And as also alcohol withdrawal was one of the initial factors which complicated the presentation of this patient. So the conclusion is that to tackle delirium in an ICU setting, a balanced management approach has to be used, which we did in this patient, and we our main base of treatment was thiamine supplementation as well as judicious use of haloperidol and benzodiazepines due to respiratory compromise. And the due to the respiratory compromise, we have to use lorazepam judiciously. Initially, when we started the patient on 2 mg of lorazepam, we started him on a very low dose because we did not want to complicate the lung condition even more, and close ICU monitoring was required. This resulted in gradual stabilization of the patient. This case highlights the importance of consultation liaison psychiatry in managing complex interactions between medical illness, substance use, and neuropsychiatric symptoms. And multidisciplinary coordination, including timely intervention, prevents complications and facilitates recovery. Thank you.
Thank you, Dr. Aditya, for that extensive great case presentation. Over to you, Dr. Malay and Dr. Rane.
Yeah, Aditya, thank you for this case. And compared to the previous one, this is, I think, the run of the mill that we all encounter in our day-to-day practice. It's one of the most commonest kind of alcohol withdrawal. In fact, a person comes for some other condition and then ends up in a withdrawal state for which he was not prepared for. And then it totally muddies the whole clinical manifestation and presentation.
Yes.
Right. Your initial dose of lorazepam, you went very cautiously in view of the chest condition and complication. He was on some oxygen flow also.
Yes.
And we know that our colleagues in medicine and respiration are quite paranoid whenever we prescribe benzodiazepines. They get all jittery when we say benzodiazepines. So in clinical experience, I would say that a higher dose would have also he would have tolerated.
I'm sorry, sir. I could not
hear me. Yeah, a little more aggressive dosing of lorazepam could have also been good. Now, tell me something, that aspiration that happened, right? I have a feeling that the aspiration that happened, that knocked the whole case out. If that aspiration didn't have to happen, then I think this condition would not have worsened.
Yes, sir. Yes, sir. Definitely.
So the aspiration usually in alcohol withdrawal cases happens when delirium starts setting in, when DT starts manifesting. So in your history, you tried and said that there was no complicated withdrawal in the past, right?
Yes, sir.
But still, that 270 ml is quite 2/4 of. It's quite a lot of alcohol that he's drinking.
Yes.
Anticipation is important, and then we know that he's got just half a lung that he's working with, right? Once it is fibrosed entirely, so we know that we cannot risk an aspiration, because invariably, I'm telling you, in alcohol withdrawal states, deliriums, aspiration is something that you have to take for granted that is likely going to happen. That's the commonest thing, complication. Could you have done something to avoid this aspiration?
Sir, other than managing the patient with benzodiazepines, what we generally, the non-pharmacological management, that is something like propped up position, and the patient has to be in a propped up position. And I think if there's not much we can do to prevent the aspiration.
I know it's not in the textbooks, but a general practice that we sometimes do in high risk and susceptible, when there are high clinical index of suspicion that there's a chance of aspiration, you might want to put a Ryle's tube.
Yes, sir. Yeah. Yes.
We might want to put a Ryle's tube, especially when he already has half a lung available to you. But I don't want this guy to aspirate. This guy is likely to go into the dose of thiamine. The dose of thiamine, of course, thiamine doses vary from hospital practice to hospital practice. I would have been far more aggressive with the thiamine.
Okay, sir.
Because you said the delirium of multiple etiologies, you're not considered Wernicke's.
Yes, sir.
Right? So a thiamine as aggressive as 1500 is what I would have used. Not just at 300. 500 milligrams 3 times a day.
Okay, sir.
Right. What are the adventurous way you could have used if your respective colleagues were concerned about sedation, right? What are the adventurous way you would have used if you needed to use benzodiazepine?
Sir, I'm really sorry. Could you repeat the question?
If you did want to
Adventurous.
use way to use benzodiazepine, especially knowing that the patient is in an ICU setting.
Okay. Sir, we could have given the patient some other benzodiazepines, such as chlordiazepoxide. Is that the question? Like,
No, is
uh,
there anything else that could have been done when sedation would not be a problem for us and we could have used lorazepam and managed the delirium and got the patient out? Is there
if
scope for
sedation was
situations?
not a problem?
Yes. How could you bypass that problem of sedation and respiratory depression?
Sir, I think the patient was mostly drowsy throughout the clinical presentation. So one of the reason being that the patient was in CO2 narcosis, because respiratory acidosis was one of the things that was happening, since one lung is completely fibrosed. So the patient was going through respiratory acidosis, and because of the CO2 narcosis, the patient was going to be drowsy no matter what uh,
What if
we
this
did.
patient was intubated?
If the patient was intubated, sir, if the patient was intubated, sir, we would have given the same line of management. That is, sir, actually, we withheld the lorazepam as soon as we suspected it was delirium due to multiple etiologies, and I think it was the right thing to do because
I don't argue with you. It's a good line. You've done it well. But in an intubated patient, would you be still cautious about lorazepam or sedation?
okay, so if a patient has alcohol withdrawal delirium and the patient is intubated, and then how would we go with the sir, I would I would
In,
still,
you'd still be cautious. In an
sir, if
ICU
it is
setting, hmm,
if it is purely alcohol withdrawal delirium, then sir, benzodiazepine is the main line of management. So I think we still have to continue benzodiazepines.
okay. What if the sodium had dropped to 114? What would be your concerns?
Sir, one of the concerns, sir, if one of the concern was would be that if the sodium is corrected very aggressively, then myelinolysis could happen. That is,
Very good.
pontine myelinolysis is one of the
Very good.
risks which we have to watch for.
Especially in chronic alcoholic. Yes.
Yes, sir. Yes, sir.
Any other in this particular case? There are
Sir,
two
if
additional
sudden hypo,
factors.
sorry, sir, sir,
There are two
sudden
additional
hypo.
factors.
So cerebral edema can happen due to sudden hyponatremia. So
Yeah,
we have to watch for
that
signs.
is there. That is there. But there are two other implications in your management if the sodium was very low.
If the sodium is,
You
so
said
how would my
you said
management change if the sodium was very low?
yeah, what would be your concerns? See, this patient has also been having bouts of atrial fibrillation.
Yes, sir. Yes, yes, sir.
And your line of management is haloperidol.
Yes, sir. Sir, yes, the
What would
QT
haloperidol do to QTC?
yes, sir. QTC value will definitely, the patient can land into
You would have,
torsades.
yes, you would have to
Yes, sir.
monitor this QTC very aggressively
Yes, sir. QTC.
because you're just relying on this.
Yes, sir. Definitely. Yes, sir.
Right. Would you want to do an EEG in a patient who's delirious like this?
Sir, yes, EEG can be done, although we did not do it because it would have been very helpful to differentiate alcohol withdrawal delirium from delirium due to some other medical condition. Because EEG would in alcohol withdrawal delirium, what we see is low voltage activity, low voltage fast activity, and in general delirium we see the background diffuse slowing of background EEG activity.
I'm not too sure about that part, but what I'm looking for here is an entity called non-convulsive status, which can be mistaken
Okay,
for delirium.
okay. Okay. Yes, sir. That.
especially when they have fluctuating levels of consciousness, which is just like
Mhm.
delirium, rapidly changing throughout the day. I would want to look for that.
Sir, I'm not very aware of this, but I'll
Okay.
definitely read about it.
Would you want to consider the CT scan brain? When would you want to consider the CT scan of the brain?
Sir, yes, we would consider a CT scan. Um, because of the sir, because the patient had an episode of atrial fibrillation and this
Yes.
hypoxia, it some ischemic changes could be noted
That could,
on
no. When there's atrial fibrillation, you suspect embolize.
embolism. I'm sorry. Yes, yes, sir.
Embolism. So you'll be looking out for focal neurological signs, especially if
Yes,
you
sir.
start seeing something, you would want to consider a CT scan.
Yes, sir.
What are the options did you have other than haloperidol? Let's say other than benzodiazepines and haloperidol, what are the options were available to treat an alcohol withdrawal?
So
And why they were
firstly, we
not
will.
suited for this patient?
Sir, firstly, we would prefer some other antipsychotics other than haloperidol. Generally, haloperidol, it has a very low propensity to cause anticholinergic effect, so we prefer haloperidol. But something like risperidone or olanzapine can also be given. And if we want, if the patient is extremely aggressive or agitated, then an alpha 2 agonist like dexmedetomidine can also be given. And if antipsychotics, according to CTP, although I have never experienced it myself, if antipsychotics fail to bring any improvement in the patient, then valproate IV, sodium valproate can also be considered.
Okay. Liver was not very compromised, you said, so you could use one.
No, sir. The SGOT-PT was slightly increased, but not clinically significant.
Dexmedetomidine have sedation and hypotension. That would be something that
Yes, sir.
may make you same problem with Lorazepam. What
Yes,
about
sir.
gabapentin?
I'm sorry, pardon?
Gabapentin?
Gabapentin, sir, I'm not very sure about gabapentin. That's why, sir,
Sedation
I'll
would have
read
been a
about
problem.
it. Yes.
Okay, sedation would have been a problem for that also. Carbamazepine?
Carbamazepine, sir, again, I'm not very sure about it.
These are things that can be used, but what's the problem in your case that you can't use it? Why you can't
Sir,
use
the
it in
patient
your
had
patient?
thrombocytopenia. So my patient had thrombocytopenia.
Same
So
problem with valproate, and your sodium is
yes,
low.
yes, and sodium is low. Yes, yes, sir.
Your sodium is low. Right. Good case. Malay, you have some thoughts?
Yeah, see, uh, complex delirium. This would be a complex delirium. I mean, if you look at from the alcohol part, it will be delirium tremens and plus so many other things. Even if you look from the respiratory system, again, uh, uh, hypoxic states, temporary or whatever ongoing hypoxic states with hyponatremia and respiratory compromise. Again, that is a complex delirious state. So the principle is one, whatever it is, we need to stabilize the delirium as quickly as possible.
Yes, sir.
So whatever we are implementing in such a situation when the patient is in an ICU setting with all kinds of monitors, respiratory support, we can try multiple things at one time, including dexmedetomidine,
Yes, sir.
because things will be taken care of. This is not just a regular ward and all that. We can use melatonin generously
Yeah.
because
Okay.
it probably
Yes,
is not going to interfere with anything else.
yes, sir.
See, one of the things why delirium happens apart from the cause, whatever be the cause, the final endpoint is delirium, would be, and whatever neurotransmitter system we are talking about. One is there is a complete disruption of the circadian rhythm. So
Yes, sir.
that has to be got into place. Two things about delirium. One is we treat the delirium, and second, we treat the cause. And both have to go on simultaneously. Now, if there is a problem with circadian rhythmicity, then we need to give melatonin in higher doses. 3 may be not sufficient.
Yes,
And
sir.
maybe round the clock also, because it gives sedation also.
Mm-hmm.
Plus, it will be devoid of all those respiratory depression effects and things like that. So, and of course, I agree with Dr. Rane. We need to give benzodiazepines. In fact, of the whole list of medications that we have, apart from melatonin, these are the safest if given as single drugs.
Mm-hmm.
And we can really build up a dose. And
Yes,
many
sir.
times what happens is that in such situations, especially with ICU settings and all, physicians would have given injectable haloperidol most of the time because patient is pulling and all these things are happening, they give. So when it comes to us, then we have to think whether we want to continue that or we want to not give it at all. In fact, there are some papers which say that the risks of cardiovascular impairment with intravenous or parenteral haloperidol are much, much less than what have been claimed. So back to
Yes, sir.
square one, it is probably the one of the safest antipsychotics which you would give in a setting like this where there is delirium, if you want to give antipsychotics. Everything else, including olanzapine, whether you want to use olanzapine, quetiapine, risperidone, okay, they are a little bit problematic because they have those additional effects. Haloperidol is pure D2. The other ones, because of the other neurotransmitter effects and so on, they may not be a very good option. You can try. If it's not working, you can try. You want sedation, you can try. Haloperidol is going to give so much of sedation. So, so, so we need to be well aware in such a situation of what our agents can do. This is actually where everything that we know or claim to know about psychopharmacology will come into play. What interactions, what are the additional effects of that molecule, maybe side effects of that molecule in a situation like this. But in that, there'll be these few molecules which will stand out, which you can use, especially because there is round the clock monitoring. Then you need to be assured, then you'll be assured that anything that is going to happen is going to be picked up very fast.
Yes.
That's a very interesting, that's the right approach which Malay is saying, especially in an ICU setting. When the patient is being monitored around the clock, you can be more aggressive in your management because the more you
Yes, sir.
prolong your delirium, the worse will be the outcome. Do you have any kind of
Yes, sir.
monitoring that you have in mind that you could use? What kind of monitoring you could do?
Sir, for
Any monitoring tools?
sir,
Would you
the
how would you
ICU
monitor
regular.
alcohol? How would you monitor alcohol withdrawal?
Sir, we can use the SIVA scale
Okay.
for monitoring alcohol.
Yes, that's very good.
Alcohol withdrawal. Yes, sir.
Yeah.
Yes, a SIVA scale is what we would use for withdrawal effects of alcohol.
Anything for the delirium?
For the delirium, sir, CAM ICU can be used, but
Yes.
it does not have a specific score for it, but we
Yeah.
can use
Yeah.
it
It's just
to,
for monitoring to see what
yeah,
you're
it's a
doing.
monitoring tool, whether
Yes.
I did not mention it in my presentation,
It's okay.
but it's a good tool to see whether the patient is worsening or it's staying the same or recovering from delirium. Yes.
I think the critical skill here is anticipating delirium. Which of your alcohol withdrawal patients are going to go into impending delirium is a skill that you have to acquire
Yes, sir.
during your residency period. Okay.
Yes, sir.
And aggressively managing it.
Yes.
Just one bit here. Clinically, delirium is two types, the hyperactive and the hypoactive.
Yes.
When patient starts pulling at things and all, it is very obvious that it is delirium. But when he is quiet, what we are doing is more important.
Yes, sir.
Because that can be a longer stage. The moment somebody pulls in, you're sure that this is delirium. So that is an instantaneous diagnosis. I mean, we also don't have to think about it because the relatives will tell or the staff will say that, okay, he's pulling. So that's their non-clinical way of saying that patient has got delirium. The challenge in picking up in this complicated cases is the quiet delirium because that can go
Yes, sir.
long. And unless and until we treat delirium quickly, there is a higher chance of residual cognitive impairment, residual poorer prognosis, especially when patients are on the elderly side. So that is one thing. And then if we are very aggressive with other treatments and we do not address, it's still something that is going on. So picking that up, and that is a tricky thing because the scales for delirium do not necessarily pick that up.
Yes, sir.
So a little change in cognition, little change, even a minuscule change in attention or cognitive impairment is enough for us to say that, okay, the delirium process has started.
Yes, sir.
Yeah. Uh, I think there was one question in the chat box, but I think it was answered. Dr. Aditya, I hope you got the answer to that question of yours.
Sincerely.
Yeah, thank you, Dr. Aditya. I mean, it's way past time today. Before we end, I don't know, is there anybody else who would like to comment before we formally end the sessions? Any senior faculty on the presentations or anything of that sort?
It's a very good initiative. I mean, people learn a lot. We also learn a lot because if you're sitting here, we also have to read something, refresh some things. So yeah, it's a good exercise for us also, and I think you should keep it up.
Sir, it's
Thank you.
there every month, and without fail, we organize it, and we pick up the very practical topics so that it would be useful for the residents.
Dr.
So
Sushil is very active at this, and I'm sure he's going to have many of these sessions. And I agree with Malay, it also is a cognitive exercise for us too. Because everyday clinical practice and actually an academic session, they're two different things.
Yes.
So yes, to formally end the session, thank you to both our presenters, Dr. Kaushik and Dr. Aditya, for very thought-provoking presentations. Thank you to our faculty, Dr. Malay and Dr. Rane, for engaging with our presenters and the audience and evoking a lot of thoughts. And yes, this brings us to a formal. I mean, it's 11:30 and people are still around, so I mean, it speaks a lot about the whole session. So thank you once again, and thank you to our students for attending. And we hope to see you back again next month for our next session.
Venona, they joined in spite of their theory exams. Means in
Oh.
Maharashtra, theory exams are going on, and tomorrow they have a second MD paper. So in spite of that, 70 students they joined. So it's really creditable.
Yes, I know.
And
It is.
if they get a question on a delirium tomorrow, they would be more wise to write their answers.
Yeah, this was it. They were interesting cases. The second one, especially because we commonly encounter that, but we do see it.
Yes. Sure. Thank you.
Thank you once again.
Okay.
Yeah, thank you.
Bye.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye, sir. Bye, Anil sir. Malay sir. Bye.
Bye.
Thank you,
Dr.
Venona.